Good morning, everyone. I think in the interest of time, we would go ahead and start. I welcome everyone to another edition of the Kunle Hassan Eye Foundation Academy Retina series. This is the 8th lecture in the series. And today, our speaker will be looking at the topic, Updates on Management of Retinoblastoma. Just to give an overview of how the program will flow, I will quickly do the welcome and introduction, which is what I'm about to do. And then we'll have the presentation from the speaker. We'll have our interactive session and then the closing remarks. Just a brief house rule before I go ahead to do introduction. Please, if you are not speaking, kindly have your microphones muted. If you have any questions, please raise your hand up. This lecture is being recorded and will be uploaded on our YouTube page. Hence, we ask for your cooperation. Only the video of the speaker at the time of presentation will be up. I'll give a very brief overview of the Kunle Hassan Eye Foundation Academy. It's part of the Eye Foundation Eye Care System, which was formerly known as the Deseret Community Vision Institute, and is the arm that oversees the training for ophthalmology residents, fellows, middle-level ophthalmic practitioners, optometrists, ophthalmic nurses, and other allied eye health workers. So quickly on to the profile of the speaker. Today, our speaker is Professor Dupe Ademola-Popoola. Professor Dupe Ademola-Popoola attended the College of Medicine, University of Lagos for her basic medical degree. She was awarded the Fellowship of the National Postmedical College of Nigeria in Ophthalmology and the Fellowship of the West African College of Surgeons in 2011 after the completion of her clinical rotations and posting. She further developed her professional capacity at various other institutions, including the Child Mercy Hospital, Kansas, United States, Emory University, Atlanta, USA, for ultrasonography, low vision and early intervention with Linda Lawrence, MD, in Salina, Kansas, United States, and the LV Prasad Eye Institute in India. She is a professor of ophthalmology, University of Illinois, and a consultant ophthalmologist who is subspecialized in pediatric ophthalmology, strabismus, ocular oncology at the UITH since 2011. She has held various positions at the University of Illinois Teaching Hospital and at various professional organizations, including being the head of department, member, top management committee, deputy chairman, medical advisory committee, chairman, hospital equipment maintenance, amongst others. She is an innovator par excellence, and the most current one is the development of the Dupe Tel Eye app deployed to create a universal access to eye care. The app allows anyone with a smartphone to refer to someone to the closest eye unit or hospital to the person being referred. It also allows specialists to see eye cases referred to them and to set up and monitor field working, providing eye care services and research. She previously developed the API Trainer Simulator for surgical and clinical wet lab training. She uses and trains in the use of smartphone for fundus imaging. She trains and supports colleagues via telemedicine to build human capacity and improve access to quality eye care in a resource-limited country where she practices. Her strength is in making a difference as a change agent, especially in addressing challenges to bring out the best. She works for the recognition of the University of Illinois Teaching Hospital as the frontline referral and training center for pediatric ophthalmology in Nigeria. She is the country lead for various international multidisciplinary team meetings for retinoblastoma and retinopathy of prematurity. She is a passionate advocate of gown to town for eye problems by building the capacity of critical stakeholders in the community for primary eye care delivery. To this end, she has facilitated the Kwara Childhood Sight Protection Law 2013, published in the Kwara State Gazette in 2014, the first of its kind in Nigeria. She's the establishment of vision screening for children at immunization clinic. She has facilitated the community vision care services in several parts of the country, as well as the vision screening for school children by teachers using a Telvisar vision screening kit at patients. She has hosted 2 international workshops in 2018 and 2013 on retinoblastoma with the support of the RB Net of London School of Hygiene and Tropical Medicine. She has several national, international recognition and has been a speaker at several local, national, and international conferences. She believes strongly in preparing the next generation of successors and has trained several medical doctors at postgraduate level with supervision of several dissertations. She has also been involved in training of medical students, nursing, post-basic nursing, and community health nursing. Her research and publications are translational and current with focus on establishing nomograms and early detection for early intervention in child eye health. She pioneered the use of laser and other focal treatment to salvage and preserve eyeballs and vision in retinoblastoma in Nigeria, and has been in the forefront of stopping retinopathy of prematurity blindness in Africa. Her works are published in reputable local, national, and international peer-reviewed journals and in books. She has over 120 journal publications. She published a book titled My Eyes, My Sight, My Health, well illustrated and written to simplify the understanding of eye condition. The foreword was written by Professor Ajeshola Adepeju Majekudumi. Her other book, The Journey Through Orbis Flying Eye Hospital and Hospital-Based Program in Ilorin. The foreword was written by Dr. Kule Hassan, who is the founder and chief medical director of Eye Foundation Hospital Group. She has been involved in the review of curriculum, conference proceeding, international classification of diseases, program development for the ICO in the United States, international pediatric ophthalmology, and strabismus. She delivered the 235th in the series of the inaugural lecture at the University of Ilorin, which was titled Illusion to Vision, a symphony through the trials and triumph of child eye health. I welcome Dr. Dupe Popoola to take on her presentation. Thank you.
Okay. Good morning. Can you hear me? Hello?
Yes, we can hear
you. All right, good morning.
Good morning.
Okay. Yes, I'm not able to share this slide now. I don't know what's going on. But,
you can try now, Ma. I was sharing my screen earlier on. Can you try to share again?
I'm still seeing your screen.
Okay.
What's good? Oh, I may have to close this. Let me just close and join back because I don't know what's going on now. But can you hear me?
Yes, ma. Yes, ma. We can hear you, ma.
Oh, so if you can hear me, because it seems frozen here, and I don't know. Look at this nonsense thing. Just give me one moment to go out and come back.
Yes, ma.
Is my slide now on display?
Yes, ma. Yes,
Thank
ma.
you so very much. Good morning. I would like to appreciate Kunle Hassan, Eye Foundation Academy, for this invitation. And I want to thank the chairman of this particular series. Let me also acknowledge every speaker that have presented in the previous 8 series of the Retina. We appreciate all that Eye Foundation has done to move ophthalmology ahead in Nigeria. And I want to recognize my seniors, my colleagues, our resident doctors who are here with us this morning. So I want to thank you for giving me this privilege to share with you what is the current status of retinoblastoma management in the world. And I'll just be paying attention to what has changed in the classification of the disease, because this is essential towards management. Specifically, I'll be talking about the role of liquid biopsy, in aqueous humor and blood, 3D prosthesis after enucleation, intravitreal chemotherapy, intraarterial chemotherapy, chemobrachytherapy, intracameral, bicameral chemotherapy, and collaboration towards improving outcome in Africa. Let me give a quick overview. I'm standing on the shoulders of some giants with respect to this lecture. I would like to present what has been done in this respect. The historic review of retinoblastoma was written by Albert D.M. and published in Ophthalmology in 1987. Very interesting history to read. Suffice to say that retinoblastoma was first identified in 16th century. So it's been with us for a while. But it didn't get its unique clinical pathologic entity until about 300 years later in the 19th century. It was Wardrop that gave that important description of retinoblastoma, and he was one who advocated for use of enucleation in management of the disease. Dunphy delivered the 20th Jackson Memorial Lecture on the story of retinoblastoma in 1963. And he proposed that there had been 4 periods in the care of retinoblastoma: the prehistologic period, the histologic period, the enucleation period, and the irradiation and chemotherapy periods. I happen to have been at the American Academy of Ophthalmology presentation in 2014 when Hans Gross-Nicholas added the 50 years that has passed since Dunphy delivered the 20th Jackson Memorial Lecture, and he added 3 other periods: the period of molecular biology, since Dunphy presented 50 years before him, the period of targeted therapy, and the period of global health awareness. This morning, I would like to add that another period has come over that, and that is actually the period of global collaboration and hope for the African child with respect to retinoblastoma. Let's just give ourselves quick reminders about what this disease is. Retinoblastoma is the commonest intraocular malignancy of childhood. In fact, it's been said to be the commonest malignancy of the eye, adults and children combined. Typically, it starts with a little tumor, like we can see on the right side of my slide here. If we don't do anything about it, it increases gradually until it takes over the eye. For many of us at my level, when we were training, we did not really know about this progressive enlargement of the intraocular disease because most of our patients came at the advanced stage of the disease. It's almost relentless, and it's one reason why we contribute to under 5 mortality. It's indeed a curable disease, still causing death in our part of the world. The history is long and it's involving all the same. It's an ophthalmology success story that a once universally fatal disease has become one in which now over 98% of children in developed countries live when they get retinoblastoma. And it's essential because we all can do something. I thank all of you here this morning because I know you're doing something and you will do much more. It's almost sure to progress if nothing is done. There is early detectable stage of the disease, and it's the only central nervous tumor that is readily observed without the need for specialized equipment. It can be seen by the naked eye when we just use an ophthalmoscope, or when there is strabismus. And retinoblastoma research and clinical care has offered significant insights to other CNS malignancy. In fact, retinoblastoma gene is the first tumor suppressor gene that has been developed. But I must say that because of certain things about the eye, even though it was the first, it's been overtaken by several others with respect to targeted therapy. I would talk more about this. It's usually found in about 3 to 5% of all childhood cancers, occurs in about 1 in 18,000 live births, or 11 out of 1 million children under the age of 5 years. And you can understand how this is important because we are a very young population. In United States, about 200 to 300 new cases come up every year, 40 to 50 in the United Kingdom, about 1,500 in India. Nigeria, between 339 and 433 cases are expected to come up, but we see less than half of this in our hospitals. Worldwide, about 8,000 cases are seen. 89% of these cases are in low to medium resource country, where the survival overall will be about 30%. Whereas most retinoblastoma centers are in the high resource country, that's just about 11% of the cases, but survival in those centers, they are now more than 97% of the children. Although 90% of these children will be less than 5 years, it's been found in some adults. In a few of the cases, about 45 have been reported in the world over. Let's remind ourselves, because this is important, to know that it can affect a child that is newly born because the disease sometimes starts in utero. From these pictures that we can see, we will see that this first child on the upper left, it was just a 3-week-old baby. It was a newborn baby, already had come with the disease. Whereas this one on the right, the upper right, she was a 9-year-old child that came up with the disease. That's the oldest that we have in our own series. And it could start as a squint. If nothing is done, it progresses to this leukocoria until it fills up the whole eye, presented as buphthalmia, or sometimes it's autonecros to present as phthisis bulbi, or it may masquerade and present as red eye, or glaucoma, it will appear like. If nothing is done, it becomes metastatic just like this other, and we can appreciate the severe pain that these children go through when that happens. It's highly chemosensitive, as shown by this orbital disease that we can see here. Just with 2 courses of chemotherapy, the eye shrunk significantly. But you appreciate that for this tumor to have come out this much, it's probably also have metastasized. And more often than not, when the children come at this stage, we really have lost the battle because it's already very advanced. In our own series at the University of Ilorin Teaching Hospital between 2013 and 2019, a lot of changes happened because of the various interventions that were deployed over the time. Those were part of the updates that had happened in our own country over the time. You would realize that proptosis, which is the one in red here, reduced over the time from being about 55% in 2013 to 10.7% in 2019. And the number of patients also increased over the same period. We will also see that other kind of presentation and squint also maintain a relatively same level over this period of time. But of note is that leukocoria increased over the period significantly, and almost everyone can identify a leukocoria. With respect to classification of the disease, we are all aware of the Recensus classification that describes the disease as being favorable or unfavorable. Once there is retinal cysts, it will say that the disease is unfavorable. And that's because in the days of Esworth, the treatment that was available, minus enucleation, was only external beam radiation therapy, which vitreous cells will not be able to take on. This has been replaced over the time by more simpler classification. We have the International Intraocular Retinoblastoma classification, intraocular classification of retinoblastoma, International Retinoblastoma staging system. These two classifications, they are intraocular. Once the disease is outside the eye, we'll be left to use the International Retinoblastoma staging system. And more recently, we have classification of the American Joint Committee on Cancer that has now added what the pathological findings look like and whether there are heritable signs. Again, the Munizetor in France, in Switzerland, they also added the classification of vitreous cysts into dust, sweat, and cloud because they have implication on response. When we diagnose retinoblastoma, we say that the diagnosis is clinical, and we need simple things to make the diagnosis, from our indirect ophthalmoscope to direct ophthalmoscope, to just even seeing that a child has squint and a stripper we're able to look. But to confirm the diagnosis, we will certainly need to have a minimum of an ultrasound that will show us the classification, like we can see in this upper image here. Or if you have your smartphone and you're able to use it to check the retina, like you can see in the periphery of this child, and with indentation, you can diagnose the disease.
Oh, we give them lectures.
Sorry, please, if you're not speaking, can you mute your mic, please? Please, can you mute your mic and turn off your camera if you're not speaking? Thank you.
We can also use a wide field retina camera to diagnose the disease.
For surgery generally.
Sorry, please, Mr. Femi Ibrahim. Mr. Femi Ibrahim, if you can hear me, please, can you mute your mic, please? Thank you.
Thank you so much. We're all trained in medicine that cancers are to be confirmed by histological diagnosis. We say retinoblastoma is an important exception to that rule because it can be recognized with great accuracy. We often do not take a biopsy before starting treatment, and that is because a biopsy increases the chance of harming the eye and making an intraocular disease become disseminated. However, the updates of recent, especially as we joined the world for the first time at the International Society for Ocular Oncology, has shown us a few other things, which are though not still advisable or practicable with respect to biopsy, and I would share that. There is what is now called liquid biopsy of the aqueous or the vitreous if you are given an intravitreal treatment. The purpose of this at this moment is really not to make the diagnosis, but is to be able to do genetic study to identify the mutation, especially when it's not possible to get information if one of the other eye has been enucleated. The biopsy could be from aqueous or blood or cerebrospinal fluid, but we know the tumor cells are often not available in sufficient quantity to produce the DNA that will help us to confirm the molecular nature of the disease from blood and cerebrospinal fluid. So, to be able to study and characterize the tumor, where genetic studies it's possible. It's liquid biopsy of the aqueous have been used in some center. We are still not advising this in our part of the world because genetic services are not even quite available at this moment in time. It will become important over time as we go on because precision medicine is now cancer medicine, or cancer medicine is now precision medicine when targeted therapy becomes available. Just like Jesse Berry's of the Children's Hospital of Los Angeles said, we would encourage that. But suffice to know that this aqueous humor will give us various DNA specimens that will help us to be able to characterize. For example, it was found that when the 6P gain is amplified in a particular sample, it portends a poor prognosis and shows that for group D disease, there's a 10-fold increase in the risk of enucleation. This is the reason why aqueous humor may become important over the biopsy over time. But for you, for me, in Africa, we will still continue to make our diagnosis as we're doing, and as it's still being done in a large part of the world. So when it becomes available, aqueous humor tumor fraction will be used to monitor diseases and be able to prognosticate which one will likely respond to treatment or not. Updates on treatments specifically. While we were training back then, every case of retinoblastoma had enucleation or exenteration, and then they were followed with chemotherapy. We still do enucleation. And the reason we still do enucleation is that 40% of retinoblastoma would be bilateral, and one of the eye will be advanced, so much so that even the best of treatments available now may not do well enough. So in every part of the world, enucleation is still a treatment option. But of note for us, for our updates, is that it's not just like any other enucleation. It must be enucleation in which we ensure that there is no perforation of the eyeball by whatever means, because we do not want to spread the tumor into the orbit if it's intraocular. Over the very many years, myoconjunctival technique has been used because it's important to also ensure that when enucleation has been done, an orbital implant has been placed, and prosthesis, ocular prosthesis has been placed, motility of the prosthesis is enhanced by this myoconjunctival technique, in which the extraocular muscles are individually isolated and then sutured to the fornices before closing to place the prosthesis later. And a long length of optic nerve of at least 15 millimeters must come out with the eyeball. The other important thing about enucleation is that we must look out for high-risk signs, which will portend the likelihood of systemic metastasis. For example, if you look at this middle lower image, you will notice that after the enucleation, you can see what looks like all these rough edges on the sclera, pointing towards the most likely of scleral involvement in this patient. And if you look at the optic nerve on the lowest right one here, you will see it looks bubbles. It's not soft. Immediately we see this, even before we see the histology, we will assume and always correct that the optic nerve has been involved. Look at this upper one. You can see how much of tumor mass came out with the eyeball. So when we do enucleation, we do not wait for histology. Assuming you assume before that this is just an intraocular disease, and then when the eyeball comes out, you now see this. If you look at this one that was done, the length of the optic nerve was about 16 millimeters. So we ensure that we have a long length of the optic nerve when we do enucleation. We look at the eyeball, look for macroscopic optic nerve invasion, evidence of scleral or extrascleral invasion, massive uvea invasion, which you can see in the anterior chamber. If you have seedling, for example, you will know that it would have passed through that space. So we say enucleation is the beginning and not the end in retinoblastoma. In addition to this, standardized pathology reporting must be ensured when the enucleated sample is sent to the pathologist. They must mention something about the post-laminar optic nerve invasion, and if the cut end of the optic nerve is also invaded, because they have implication for treatment. Once this happens, that patient must have chemotherapy in addition to enucleation. We will document involvement of anterior segment and see if there is massive invasion of the choroid of more than 3 millimeters, invasion of the sclera, which might not have been visible macroscopically, or if there are extrascleral tumor seeding. After enucleation, we rehabilitate the eye. We do not just put prosthesis. We want to put a prosthesis that fits as closely as possible to the other eye. We're aware that custom prosthesis is the best. Up until recently, custom prosthesis, they are usually done manually. They take like 2 hours. Apart from creating a mold, then the ocularist sits down and paints the iris onto the prosthesis and use colors that matches the other eye. But of note is that we now have what is called 3D printing of prosthesis for an ophthalmic socket. This was reported by Mandip Sago of Murphy's Eye Hospital and Retinoblastoma Service. With anterior segment optical tomography, they have used machine learning to generate 3D printed file, and this can happen within 30 minutes and will make the prosthesis available for that patient to use, improving rehabilitation and, of course, almost an exact replica of the other eye. Let's have some updates on chemotherapy. You know that chemotherapy in retinoblastoma can be intravenous, intravitreal, intracameral, intraarterial, and chemobrachytherapy. I will talk about each of these shortly. And usually chemotherapy alone does not work. It has to be combined with a focal treatment like laser being used here, which here we're using thermotherapy from 810 diode laser. It eats up the tumor and improves the absorption. Remember that there is blood ocular barrier. So the laser, apart from treating the tumor directly, also breaks down this barrier, improving absorption. So that is the reason. Even if you have just the opportunity to do chemotherapy, we should ensure that there must be focal treatment before treating the patient, because we would have lost time and opportunity to have a chemosensitive tumor respond appropriately by doing focal treatment as we do chemo treatment. Intravitreal chemotherapy using melphalan or topotecan in cases of vitreous seeds can significantly improve the outcome for the patient. Like this, our patient, before we had access to melphalan and topotecan, we were using methotrexate, and a patient with this stage group D disease with this vitreous seedling that looks like spheres scattered all over the place, in addition to subretinal seals that this patient has, with intravitreal chemotherapy, you will see that the seeds dried up and the patient could have a better outcome. It is indicated when we have active vitreous seeding, and it should go concurrently with intravenous chemotherapy. But this needs to be given every 7 to 10 days and we can understand how challenging this would be for a typical patient in our own part of the world. And sometimes it's required if an intraocular surgery is needed by the child. It's been found that when we have dust type of seeding, an average of 3 injections will be required. If the seeding, they were like spheres, it will be about 4, and if they are clouds, about 6 injections would be required. The outcome of this shows that it takes about 2 to 3 weeks for dust type of seeding to regress, 6 to 7 weeks for the sphere type, and up to 30 to 32 weeks for the cloud type of vitreous seeding to improve. What is the outcome of intravitreal injection? We have done a few in our own center, but there's a center that has done quite a lot over the last 10 years. And the report here is that in about 94% of cases, Mephalan is what was used, and it was possible to preserve the vision in the majority, in over 85% of those patients when intravitreous Mephalan was added. But it's been found that topotecan is less toxic than intravitreal Mephalan. Then we have the intraarterial chemotherapy, which could be used as a salvage treatment. In other words, when nothing else works, this can come on board. But in several developed countries, it's now a primary treatment in which the ophthalmic artery is cannulated, and then the chemotherapy, they are delivered directly. And sometimes they are used as tandem treatment in which bilateral treatment is given on the same sitting. This intraarterial chemotherapy was actually first described by the Japanese team in 2004. And all manners of work continued until about 2009 when it got a lot of adoption. Now it's being performed in Africa. It's been performed in Kenya, it's been performed in Ghana, and we performed in Nigeria, thanks to Sheba Medical Center and RBMDT for supporting our first intraarterial chemotherapy in January of 2023, where 3 eyes of 2 children had chemotherapy done by a team from Israel and Nigeria to give vision to our children. And we did another one on the 31st of August, this time around by ourselves. Just the Nigerian team alone did a second one in August of 2023 with fantastic outcome for the patient. What was found is that on the average, the glow salvage rate is as high as about 77% in these cases. The survival estimate is about 43% for eyes that are seeding because it doesn't help such eyes. Now we go to our update on intracameral or bicameral chemotherapy. In intracameral chemotherapy, we use the treatment when the retinoblastoma has gone into the anterior segment with aqueous seeding, and it involves injecting the chemotherapy into both the anterior and posterior chamber of the eye. Again, the Switzerland team have done a lot of work on this over the last 10 years, and they have been able to save over 70% of the eyes at the first onset. Actually, 85% of the eyes were saved, but over time it dropped to about 70% as many others became enucleated there. And the most exciting one of our update today is about the improvements coming to retinoblastoma care because of collaboration for the African child. We have these various groups and several others to thank: RBMDT, RBNet of London School. We have Sheba Medical Center, who has taken it upon itself to support African institutions to start intraarterial chemotherapy is extremely expensive because we need a cath lab, we need an interventional radiologist, and we need the micro catheters apart from the medication. We have AMCC working in several parts of Francophone country and in a few of Anglophone country. We are hoping to collaborate with them to support a few more centers in Nigeria. We have Orbis International. We have the center in Canada also supporting the Kenya team. And we have St. Jude Children's Research Hospital supporting the Ghana team and such. The update is not lost on the use of monoclonal antibody, which is being used, of course, in treatment of other retinal diseases already. The denosumab is the recent one that has been found to act as a bridge in targeting even retinoblastoma that has escaped the eye because it finds the receptor to bind on and triggers antibody-dependent cell-mediated cytotoxicity, which leads to massive death of retinoblastoma cells. We're anxiously looking forward to making this one available for everyone. Update on our retinoblastoma in Nigeria and our roadmap. We initially did not understand the disease because we saw only advanced disease. Then we had opportunity to train in ophthalmic oncology. We piggybacked it on pediatric ophthalmology and primary health care with a lot of media engagements, which made the patient to come earlier, like you saw in the chart I shared earlier. Other people were trained in the process. We established MDT communication platforms. We have what we call RB Team Nigeria, RB Team West Africa, RB Team for patients communication. We then started amongst ourselves educational program. Later we upgraded, we began to have virtual parents to parent counseling, and we've been involved in several multinational research collaboration efforts, thanks to Didi Fabian. And then we established different types of patient referral and care system. And most recently, we participated for the first time as the International Society for Ocular Oncology was brought to Africa. We went in our numbers and we ensured that we used the opportunity of that meeting to make major advancements for Nigeria. I want to thank my trainers. These men in my work and benefactor, they are my benefactor in retinoblastoma, Sad in Egypt, who was my most direct trainer in year 2009 after I had a stint at India, and Ashwin Reddy, where I also went to at Royal London Hospital, and Didi Fabian for all he has done and is still doing. So we organize international workshops supported by ARBINET, 2 of these. We have grants from Murphy Kolebu to support with 34 pounds the care of each child with retinoblastoma. We established RBM MDT that takes place once in a quarter. We have one coming up tomorrow where we present our challenging cases and our plots and plans with respect. I've talked about us having the IAC. We were able to, we have been advocating, and currently we're deciding amongst ourselves, because retinoblastoma is very expensive. It's a disease that should be picked by all, but not actively managed by all. You can see the varying array of treatments available. Is one in which you need very focused and dedicated people and very intense. And in progress, we're working on registration of retinoblastoma Care Alliance of Nigeria. We are contributed to the National Policy on Cancer Care document. We were just on time about 4 weeks ago to be able to contribute to that document. And we're currently also trying to develop a national guideline. So the summary for retinoblastoma is that it was identified as far back as the 16th century, and there has been continuous improvement. The advancement up to 1900 was the availability of light microscope, ophthalmoscopy, the introduction of enucleation, chemotherapy, and radiation therapy. The last 50 years saw the discovery of retinoblastoma gene, genetic testing, which is a game changer, plaque chemotherapy, chemo reduction with focal treatment, intraarterial chemotherapy, and intraocular injection into the different chambers of the eye. The current status is that nearly all patients in developed countries can be cured of this primary cancer, which is a remarkable achievement for a childhood cancer that was once uniformly fatal. African children are getting better at fighting the disease through various collaborative efforts. The future challenges remain that all children everywhere who have retinoblastoma be able to have early detection for early intervention. My recommendation is that all hands must be on deck to improve the knowledge base among all people. Social and Economic Association of Retinoblastoma needs to continue to be placed at the front burner, and we all must contribute to improving this. We thank the people supporting us in various ways. Collaboration must continue. In this case, all health centers would be able and people identify and then refer children in a timely manner to centers where appropriate, correct, comprehensive, timely intervention can be provided. While we continue to participate in research, clinical trials, and targeted therapy, we have a long way to go in this, but we are going to get there. Our African children now live and see in spite of retinoblastoma, but the light is still dim. This race continues. I want to thank you for listening, and I pray join our train as we continue to join the world to bring life and sight to children of Africa who come with the once fatal disease. Thank you so much for listening.
Wow, thank you so much, ma'am, for the very enlightening lecture and for honoring our invitation. We'll now take questions from our guests that are online. If you have any question, please raise your hand or type your questions in the comment section. Thank you. There's somebody's hand is up. Dr. David, please unmute your mic and ask your question. Thank you.
Good morning, ma'am. Thank you for the very enlightening lecture. Please, I have two questions. One is there any risk for extravasation or metastasis with liquid, aqueous liquid assay? And if there is, how is it minimized? The second question is, if there is, thank you for the list of the management ways to manage the treatment modalities. Is there any consensus on the different a flowchart like of what to do at a particular stage, and especially in Nigeria, the specific places to refer if one gets to that stage? Because for me, I know that most times once we pick it, everybody just sends to Lauren, to know if there are other places to go to that are nearer for patients, so that some will not be missed. Thank you very much.
Thank you very much. Let me take this one while waiting for other questions, if there are. Yes, the risk of extravasation and spread of the disease happens every time you put a needle in the eye. So what is done typically is that while the technique of taking that biopsy is also specialized, you go through a long route through the cornea before entering the anterior chamber. And after taking the biopsy, then triple cryo is placed over the entry point so that if there's any tumor, it's going to be killed by that cryotherapy. Yes, for every intraocular disease, depending on the stage of the disease, you know, this lecture is just on updates, on treatment. It's not, we can spend a whole day. After all, we spent two days talking about retinoblastoma at an international meeting. Depending on the stage of the disease, if we have early stage, focal treatment alone may just be okay. Laser, if you have a stage, a group A disease, for example, which is not very common, unfortunately, in our own part of the world. Even in other parts of the world, because of surveillance is why they get it. They get the surveillance in survivor or retinoblastoma. And if it is more than that, chemofocal treatment becomes indicated. Beyond that, we may need to use brachytherapy. I mean, you can see all the treatment options, intravitreal, intraarterial, it depends. Once you have group D disease, that means the seeds are all over the place. You need something more than just the intravenous chemotherapy. So we know that. But remember that I mentioned that it's very essential to have focal treatment with chemotherapy. And so, I mean, you can answer the question, is there someone in this center? Even if you have the focal treatment, are you interested? It's a lifelong disease. It's a lifelong management. Even when you have controlled the tumor, you still see this child, depending on the age. You start initially every 2 months, every 3 months, every 6 months. So it's not just something you want to touch and go. But we know that in Nigeria, we were deliberate because I realized the travel distance is really challenging for the patients. We started way back in 2007 in Ilorin, so 16 years now. National Eye Center, I believe, should carry several of us. And so deliberate efforts was taken in that direction. And initially, we were having discussion about patient duty. Then I had the opportunity to be there to build capacity with my colleague there. And thereafter, we still support one another. We started the same way with George University Teaching Hospital. Over the time, because of the availability of focal treatment at the National Eye Center, a lot of patients are also being taken up in that place. Many of our other centers are still about this. So many centers are able to do something or part of treatment and then refer over. But when our guideline document comes out, it will be made clearer because everybody will then identify this is available in my center and I'm able to use it. Not only am I able to use it, I am willing to do the long run for these patients. And intraarterial chemotherapy, for example, if a patient is able to afford it, we don't have cath lab everywhere. So we need to go to where it's available. Thank you. I think there's another hand up. We have 1 minute.
Yes, ma'am. Good morning, ma'am.
Good morning.
This is Dr. Gabriel. Thank you for the presentation, ma'am.
Oh, Dr.
My attention was due to the monoclonal antibody that is used in the treatment of retinoblastoma. You said when there is an extraocular. I was thinking at what stage of the extraocular disease that we think that the monoclonal antibody can be effective. Thank you.
Thank you very much. You know, if it's given as intravenous, that means if we have an orbital disease, it will get there. Hopefully, if it's just regional metastasis, it will get there. But this is, in fact, it is still largely experimental, even though FDA is strongly considering approving it. So it's not something that is, and you know, when such things first come out, it's not accessible to us financially. So if there's regional metastasis, I'm praying that it works. It works as it's been expected to work when it finally goes into the clinical phase and everybody is using it. So it's given intravenous. So if there is orbital and just regional metastasis, we are assuming and praying that it will be able to pick that up. And that will be a game changer in the management of retinoblastoma, especially for us. But more importantly, the patient should come early, just like any other cancer. Thank you.
Thank you, ma'am.
There's another hand. Maybe the person should unmute. I don't know who this is.
There was somebody's hand that was up. The name is not showing. Please, if your hand is
Okay.
up, kindly unmute your mic and ask your questions, please. We're about to round up the session. If you have any questions, please unmute your mic and ask your question.
Okay, I don't know if you can hear me. Yeah, I was actually thrown out, so my name did not show now. I don't know if you can hear me. Thank you.
We can hear you.
Okay, thank you. Thank you very much, Prof. I thought I knew something about retinoblastoma, but I found out this morning that I know nothing. Just a simple question. You're mainly a referral center. Have you found what the prevalence in a particular part of Nigeria? Is it more prevalent in the south, in the north, in the southeast, from a particular region? I don't know if my question is clear.
Your question is
Have you
clear.
found? Yes, ma'am.
Your question is clear. My answer to that would be to say a cautious no, because our national study actually was hospital-based, as you would expect. And in any community where you have consanguineous marriage, you expect it to increase because 40% of this cancer is bilateral, and all bilateral diseases are genetic. Do you understand me? But I'm cautious in answering that question to say that it's commoner here, because we have seen retinoblastoma from everywhere. We have seen retinoblastoma from every socioeconomic group, from the poor to the rich. But let's remember that the poor are more likely to be at the risk of epigenetic issues, unnecessary use of insecticide, nutritional issues that may make them have more challenges and not being able to pay. They're likely to come late. But we have seen from the richest to the poorest. Doctor and nurse as parents, very rich people who live in big places as parents. But I expect that when we finally record all our findings, if we have a particular community where you have consanguineous marriage happening, it's likely to be more there. Thank you.
Thank you very much. My name didn't show. Ayo Harriman. Thank you.
Yes. Oh, thank you, ma'am.
Okay, thank you very much, Professor Popoola, for taking us on this very beautiful lecture. We've come to the end of this lecture series. The Kunle Hassan Eye Foundation Academy appreciates you for honoring our invitation to speak at this lecture. We thank all our guests for taking the time to join. The Retina series happens first Wednesdays of the month. We'll be sharing updates on when our next lecture series will be taking place. Thank you all so much. Thank you very much.
Thank you. Thank you so much for having me. Thank you everyone for coming. I recognize Dr. Kunle Hassan. We appreciate you, sir. Thank you.
Thank you.